Welcome to the Optimal Care Pathway for Aboriginal and Torres Strait Islander people with cancer webinar looking at prostate cancer. We recognise the traditional custodians of the lands and the seas on which we live and work, and we pay our respects to elders past and present. And now to the good things. Today's presenters are Associate Professor Justin Tse. Justin Tse is Clinical Dean at St Vincent's Clinical School at the University of Melbourne. He has been involved in medical education for 20 years and has interest in intern readiness and e-learning. He is also involved in cancer research and completed a thesis on prostate cancer screening. He is a primary care physician and also serves as a research fellow with Cancer Council of Victoria and an advisor to the RACGP on cancer-related care. We are also joined by Dr. Timothy Senior. Dr. Tim Senior works as a GP at the Aboriginal Community Controlled Health Service in Southwest Sydney and holds clinical lecturer position at the Western Sydney University and Sydney University. He is also the medical advisor of the RACGP Aboriginal and Torres Strait Islander Health faculty and chair of the Environmental Impacts in General Practice Network in the RACGP National Faculty of Specific Interests. He writes on general practice, the social causes of ill health, and successfully crowdfunded Wonky Health, a column on the Croaky Health website on the health effects of policy decisions. He also won the Gavin Mooney Memorial Essay Prize for an article on the language used in climate change campaigning. We are also very lucky today to be joined by Mr. Ken Lechleitner from Tu Ilpa Bicultural Consultancy. And Tu Ilpa means to hear with both ears in both cultures, to make sense of one's own cultural world and other people's cultural worlds and find that solution. And now, Dr. Tim Senior will start the webinar.
Thank you very much, Daniela, and good day to all of you. I hope you're all staying well. These are the learning outcomes for today, which is the educational speak for what we're hoping to get out of the next hour or so. So by the end of this webinar, participants will understand the optimal care pathways, their themes and principles for providing effective, culturally responsive healthcare for Aboriginal and Torres Strait Islander people with prostate cancer. We'll be able to identify the risk factors for prostate cancer. We'll discuss some of the barriers to effective implementation of follow-up treatment and monitoring, and we'll identify strategies on how to apply the optimal care pathways, resources and knowledge to improve our own practices with prevention and early detection of cancers for Aboriginal and Torres Strait Islander people. So the optimal care pathways are a series of resources produced by Cancer Australia, partnered with the Department of Health and Human Services in Victoria and the Cancer Council of Victoria. And there's, we'll see in a minute, there's different pathways for individual specific tumours, but there's also a pathway describing the optimal care pathway for Aboriginal and Torres Strait Islander people with cancer. And it complements the tumour-specific optimal care pathways. So the idea is that you use them both in conjunction with each other. And it contains guidance for health practitioners as well as service planners on what ideal care for Aboriginal and Torres Strait Islander people with cancer through from screening and diagnosis and all the way through treatment and post-surveillance, what ideal care looks like for Aboriginal and Torres Strait Islander people with cancer. And one of the reasons for doing that is that we know that while the incidence of many cancers in Aboriginal and Torres Strait Islander people is the same or lower, the mortality is often higher. They're often diagnosed later, or people have more difficulty continuing with treatment. And so these pathways are designed to help overcome those obstacles. And so the Aboriginal and Torres Strait Islander optimal care pathway is designed to be used with all of the specific cancers guideline documents. And these are the key considerations that they have about understanding the patient, about really good communication with our Aboriginal and Torres Strait Islander people, and also ideas for practical considerations for our consultations with Aboriginal and Torres Strait Islander patients. None of those three would come as a surprise to us all working in primary care with Aboriginal and Torres Strait Islander people. It's also important to think of systems of care. So we have most control over our own consultations, but often the journey that people have through the organisations, health services that provide care is not as good as it should be, and we all hear those stories quite frequently. And so it's important to think about those systems and how they're working for Aboriginal and Torres Strait Islander patients, and how we can advocate on our patients' behalf to make their experience of health services and health systems better than it has been in the past. And as GPs, I suspect most of us are GPs, but as GPs and primary health practitioners, we all know it's really important to understand things like people's context, how what's going on in their family, what's going on in their social circumstances, the sorts of information that they have access to, and ways of getting information, and ways who they get information from. It's important to think about how accessible services are, either geographically, particularly in rural and remote areas, but also financially, and whether people actually have transport to services, and also whether people are going to feel that they're treated fairly right from entering the door, and in their interactions with receptionists, with nurses, with doctors, and with all sorts of other health professionals. And so we need to understand quite a bit about the patient context to do all that. We'll go into some of that in more detail. I'm going to hand over to Justin for some of the statistics relating to prostate cancer.
Thanks, Tim, and thank you for the opportunity to present today. Just to start off with prostate cancer, and these are some statistics regarding the general population. So as you can see on the slide set, 19,000 or just over 19,000 males are diagnosed each year with prostate cancer, and these are 2019 figures. Of all the cancers, it represents 25%, and it is the leading cancer in the general population. Each year, 3,306 deaths occur from prostate cancer, and this represents 12% of male cancer deaths in Australia. The 5-year mortality rate is 95%. That's been steadily rising, obviously with people being tested and treated with latest management options, which includes surgery, radiotherapy, and other treatment options. Currently, over 90,000 men are living with prostate cancer, and this is some figures from 2014. Maybe moving to the next slide. With the Indigenous health population, this is the second leading cancer, with the #1 cancer being lung cancer. In the First Nations population, it is underdiagnosed compared to the general population. And between 2009 and 2013, there were 526 new cases, representing an average of 105 cases per year. In regards to deaths over 2011-2015, there were 83 Indigenous Australians who died from prostate cancer, an average of 17 deaths per year. So in summary, 5-year mortality rates, there is an 86% on average that are alive at 5 years. And this is compared to the general population, where the 5-year mortality rate is 92%. So moving, I guess, to a really important slide, just to set the scene for this afternoon. With the summary, if we could go to the next slide, it is prostate cancer underdiagnosed. And if diagnosed and treated, the 5-year survival rates are worse than for general population. And that's why today's webinar is pertinent, so that we will be able to review prostate cancer with a First Nations focus. And we'll focus now over the next few slides on prevention and screening, diagnosis and management. Before we do that, I just want to go through the current prostate cancer screening guidelines, and these were set in 2016. It's a consensus statement which has been agreed by the Cancer Council of Australia. It had PCFA involvement along with endorsement by the RACGP. Most of you will know these guidelines, but just to summarise, the current recommendations of 50 to 70-year-old men should be offered the pros and cons of PSA testing and therefore be able to make an informed consent. At the moment, the rectal examination is not recommended as part of the screening guidelines. And if testing is normal, we will retest with consent every 2 years. Those unlikely to live more than 7 years should not be offered the PSA testing for screening. And the fact that with medical training, we often mention as students that many patients will die at this stage of other diseases rather than prostate cancer. So obviously not to offer inappropriate testing. However, we do have an older population that's living longer in the general population, and those over 70 years old should have a detailed discussion about the benefits and harms of testing before deciding whether a test should occur or not. And with all things regards to health literacy and information to our patients, the role of decision tools is very important in informed consent. Over to you, Tim and Ken.
Thank you very much. So, as Justin was saying, that prevention and early detection is really important, and I think it's important. Certainly, in my work with Aboriginal and Torres Strait Islander people, there are often other comorbidities, both in terms of diseases and in terms of people's social circumstances and mental health as well. And I think it's important that we understand that. I mean, obviously, good communication is really important, but also the fact that people's level of knowledge isn't zero. They've often seen, had discussions in family and in community, and so it's always worth checking what it is that people already know and understand. Ken, in having a conversation like that with someone, what are the sort of approaches that you would take for what could potentially be a tricky subject to broach, talking about cancer and particularly it being a men's health issue?
Okay, can you hear me okay?
I can hear you really well, thank you.
Yeah, okay. All right, look, thank you, Dr. Tim. Now, look, with the first thing in regards to communication is that this is something that we try to advocate more, is that for the doctor to actually tell a little bit of story about who they are, where they come from, and where they've grown up. Because what that does is it brings it down to a personal level of your patient understanding, oh, there's another human being that I'm actually talking to that actually grew up in this region or come from that region over there, and I know that, and then we have something in common to share. So it's then sort of, you could talk about what's your common sort of footy teams or things like that. And that opens up communication. That sort of develops trust. Is okay, this is how I can actually talk to my doctor, or the doctor can talk to me. You're finding that sweet spot in how you communicate, because otherwise you go in and it's like, oh, this doctor is gonna, oh, how do I talk to this doctor, because I've got a problem, but is this doctor going to able to read my mind? So to overcome all that things, we've got to be able to sort of kind of introduce ourselves and say, where do I come from? Where did I grow up? And then we go, ah, you're just another person like me, but we've got certain common interests. We can then talk like this. So communication is really important, but we've got to be the presenters of it, and also the ones that kind of like advocate that by sort of being the sounding board as well, because we don't normally have a flow on communication like a tennis game. You know, like someone says something and you respond. There's absolutely silence on the Aboriginal patient's point of view, because it's like we're trying to think about, how do I respond to what the doctor's saying, because one person might have limited actually English capacity, and then trying to articulate that back in the limited vocabulary becomes a little bit difficult as well. So we've got to ask people by getting them to paraphrase, or you kind of say, look, I've given you a lot of information. Can you tell me what it is that I told you? Because that's the only way you can really understand that you've communicated something across. Guys, am I making sense there?
Yes, you are.
Yeah, so that sort of kind of helps with community and using for more complex sort of kind of medical terminologies or conditions is that you use pictorial sort of presentation or like or reference to a car body. People, men especially, understand cars. So I had to explain to a patient that was in a process of proving to the doctor that yeah, I'm okay to get on to becoming on the treatment of dialysis, where he was absolutely umming and ahhing and saying, oh, I don't really want to. But then when I explained, look, it's just like your petrol filter. That's no good. That's your kidneys. And it's no good now. We got to need to sort of kind of clean it another way. So he was able to take that sort of kind of a vehicle analysis of what a petrol filter does and referred to his kidney. And then he said, okay, yes, okay, I understand that now. I'm happy to go down this path of getting the treatment or, you know, getting hooked up on dialysis.
Ken,
So
I've
we've
got a
got to
follow-up
be,
question. Can I ask Ken, just with diagrams, do diagrams help if, let's say, a doctor decides I'm going to explain this maybe through a
yes,
plain piece of paper, draw a diagram? Is that of help
yep.
to the Indigenous population?
That's all very helpful. And also when an Indigenous client might say, can I have my grandson or my sort of kind of brother, younger brother with me? Because that helps the actual conversation after the doctor's visit too. Because it gives them a discussion to deal with that issue in a much deeper understanding. Otherwise, you know, we get caught up with, oh, there's only client doctor sort of patient confidentiality, but this is where you'll find in our region, an elderly will request a younger person to be present at the consultation to help with the actual communication and understanding. So, yeah, and because that's what we want is the patient to understand where they're at in their sort of kind of journey with their illness. So there's a lot of little sort of kind of messages in there, but using pictorial sort of kind of backing with a family member as a support to help a much deeper communication would help eliminate this sort of kind of communication problem.
That's excellent, Ken. Thank you.
No worries.
I think the point about other people being present and who the patient wants to be present is really important. I always find that help from an Aboriginal health worker is really helpful, both in knowing the family and the context and what's going on for that person, but also being able to talk about things in a way that people will trust. It's probably just worth mentioning that as a male GP, I'm able to discuss this with people. It doesn't mean that female practitioners can't, but often it's worth checking beforehand. Are you comfortable talking about this with me, or do you rather talk about it with a male health worker or male doctor? And people will let you know. Some people will say,
that's
yeah,
right. Yes. Mm-hmm.
That's right. And some people will say, oh, I'd be much more comfortable. And some people will say, oh, you're my GP, I'd rather discuss it with you. So don't assume. The other thing I'm aware of, Ken, as well, is that we've got family history down here. Many of our patients may not know what their family history is because it's not continuous. They or their grandparents or their parents may well have been stolen generation and not know who their family is.
Yeah.
And that can bring up quite a lot of issues for some of our patients too, can't it?
It does, because it's like sometimes that part of the family history is not always known either. So that presents another complication. So and if there isn't sort of kind of any other sort of family that's been involved in, say, another family member's like journey with an illness, then it's harder to share that sort of kind of family history, unless people sort of kind of say that, oh yeah, my uncle so and so, or my older brother cousin had this, so it's in the family, which
Yeah,
then helps families sort of kind of come up with their own strategies of how do they look after each other. So it's certainly very really important to have this family history check, because then people know that this little bit of sort of illness is like passed down generation and generation.
Absolutely. We know it's important for prostate cancer risk, certainly,
Yeah.
but it's an issue to be approached sensitively. I think being aware that our profession, we're involved in stealing children, so it can still be a raw issue for
Yes.
many people, so to be approached really sensitively. We move on to the next slide. Again, this is around informed consent. Now, the principles of what we do here aren't any different to the principles that we would be using for informed consent for anything else at all. And we really need to make sure that the patient is able to be happy with the decision they've made either way, so that they're comfortable about they've got enough information to make the decision and they're happy with the decision that it's made. And I think the things that Ken was talking about visual representation and not using jargon and being able to discuss it with a trusted person or more present all go for this around informed consent for PSA screening. There are some really useful visual guides. I think the New Zealand Guidelines Group do one, and I think the college have had one about the number of screening tests done and the number of positive results you get, and then the number of negative results. And that can be really useful for talking people about the risks and the benefits of doing the test, and then what the test itself involves. Is there anything you'd add on that, Ken?
Yes, with this consent to it, we just got to explain that, well, this is what you do and you're getting permission, and what we're starting to discover what really works as well in regards to far as communicating sort of kind of a longevity is that we use the AFL 4 quarters. The first 2 quarters you're only just growing up and living, and you hit half time, which is you hit around about 50. Now this is where we say, well, third quarter is an important quarter if you want to get in front and win this game, or be ahead when the siren goes. So you're giving people to understand, look, well, I've got sort of injured on the side. Now this injury, how am I going to sort of kind of, play this out, play out the third quarter into my sort of fourth quarter? So people understand fourth quarter is when the siren goes. So it's understanding the big picture in regards to my journey is now this. I've got an injury. And people will understand. So, am I making sense there as well? Because people understand that there's only limitations in regards to 4 quarters in football, but you put that into sort of kind of age group and time frame, people understand. Oh yeah, I am running out of time, but I just need to do the best I can with what I got.
I really like that. I haven't heard that before, and I think I like that 4 quarters analogy. I'm aware that you're in the Northern Territory and Justin's in Victoria, so you'll be right across the AFL stuff for viewers.
Definitely.
Like myself, yeah. I imagine rugby league.
New South Wales, it could be the second quarter, like second half, 20 minutes into the second half.
That's right. So we can adapt this analogy to suit our own patients. You may get strange looks talking about AFL to some of the New South Wales or Queenslanders patients, but I think that's a really helpful analogy about sort of the different stages in life, and talking to people about the different approaches that you take at those different stages in life to actually get to the end of the game.
Tim and Ken, just a practice point, and that's where a patient may be, after a discussion, let's say he's 53, after discussion with family members, the patient decides not to undergo PSA testing. One of the things as a practice point is that in a year's time, 2 years' time, it's a conversation to revisit. So you start again with, well, this is prostate cancer. Obviously, look at risk factors in your family history. Go through an informed consent, going through the pros and cons. So it's not a static decision, but a decision that may change over the course of time.
Absolutely. And I think that's really important. People have the right to change their mind, and we'll have talked about it with family members and with other men, and so want to rediscuss it. And it's one of the fantastic opportunities we have as GPs, is that we do have that relationship over time, that we can revisit conversations like that months and even years later.
Yes, and let's not forget to use that football analogy. It's more or less like, you know, you're taking yourself out of the game, but to be in part of the game is to be part, you know, playing it actively and taking active treatment and all of those things is playing the game. So playing the game of life. So you could use that, you know, otherwise you could sit on the bench for a little while and then come back in. But, you know, you've got to make that choice.
Absolutely. I think it's
Very
worth...
well said.
Yeah, absolutely. I think it's worth pointing out as well that our role here is to allow people to make a decision that they're happy with, rather than to persuade them in one direction or other. And I think the crucial importance of this is that for over 200 years, we've removed the right to make decisions from Aboriginal and Torres Strait Islander people. And so we actually need to, part of our role is giving that back to people so that they are making their own decisions, and that people who are able to have control over their own life are actually happier. So so we're not persuading them one way or another. It's about, as far as we can, allowing people to make decisions that they are really comfortable with, and that can change over time.
Yep, that's it. Yeah.
So if we move on to the next slide, this is an important aside around the records and the and computerized records. In primary care and general practice, we're all fairly, like, general practice is using electronic health records much more than the hospital systems are, I think. And again, for the role of screening and then the tracking of people across diagnosis and surveillance, the use of electronic healthcare records are really important. It allows us to use disease registers so that we can easily bring up a search, a list of all the people with prostate cancer, or a list of all the people with other cancers, so that we can be systematic in doing in providing care at particular points in time, and using call and recall. And I think and so that's really important in conditions like cancer, where the stakes are high. So we do need to be able to diagnose early and diagnose recurrence and track people's health as they go through treatment. So our records obviously are our friends here. And I think the other important thing as well is that for many patients, the use of My Health record may well be important here, because it allows us to document with the patient the precise diagnosis and a plan of care and a summary of their medical care, so that for people, particularly Aboriginal and Torres Strait Islander people who might be quite mobile between different clinics and between different services, the ability to share information reliably through something like My Health record can be really important for continuity of care and for and for allowing more certainty over what's happening for that patient.
Tim, just to emphasise the point, it's not only the health summaries, but increasingly, and we're hoping the hospitals over the next few years will have more buy-in to the My Health record, but we're seeing a lot of chemists now able to put information into my health record. You can also see blood tests being done. And we know many patients, even let's say if they're not mobile, they'll go to multiple pathology services and just be able to see a kidney function test over a period of time spread over a number of providers. That gives you a context, particularly obviously with renal disease being a concern with Indigenous health population.
Absolutely. Yeah, that's been
yeah, sorry, Doctor. If I could say something there, that sort of in this little community of Alice Springs, we have that scenario as well. We share, I think our files get shared with the state sort of kind of hospital system and also the private sort of health clinics. And also what's good about this is if you're sort of having a patient care plan, then you're able to sort of kind of ask about the patient care plan. Okay, how's your plan looking? You know, I heard that this clinic over here has developed a plan for you. Then are you still happy with this plan? We continue with this plan. So it certainly does give that client or patient an ownership of their plan. So, you know, to either, start eating more healthier or start monitoring that, or where it's been referred to a nutritionist or something, to look at sort of the food consumption to help with the, the condition. So, yes, sharing records like that is fantastic with their sort of patient care plan.
That's really good and clearly really important. And if the way we're using our health record is engaging patients actively in their care, and any other way we can do that, and that's going to be much more successful in terms of the management and in terms of the patient achieving what they want to manage.
Yeah, and something that's actually appropriate, like someone might not be able to go to a gym, but you explain, look, you can get these exercise by going for a walk or doing your yard. That's the kind of like the activity we want you to do. If you're raking up or you're doing sort of something around the house, that's sort of kind of is the kind of level we want you to start with, not sort of go to the gym, because you probably won't be able to sort of go to the gym. So we're going to find it realistic.
Absolutely, and I think that's really important. Is plans are going to work in that person's context,
yes.
Not a one-size-fits-all approach. If we move on to the next slide, prevention, early detection, and follow-up. I think Justin, you're going to start off on this.
So the role of GP is crucial post-diagnosis and discussion of management options with any cancer, but particularly with prostate cancer. And look, with any patient, it's important that we do it in a quiet setting. We obviously observe and obviously understand where the patient's coming from, particularly from a health literacy point of view. And yeah, for me, explaining a positive diagnosis with a PSA, yes, we have 2 readings that is positive, and then we talk about the importance of the next step, and through a discussion about needing going to a urologist, possibly a biopsy, and then some of the technical language with the Gleason score, and that's important because that will actually determine treatment. So explaining a positive diagnosis, it's really important to understand what language is used, again using pictorial diagrams, and obviously using of ratings. I guess from a patient-centered approach, maybe looking at some enablers and barriers of care and any optimal care pathways. The prostate cancer pathway is being revised as we speak, given it's been many years since the first iteration of the OCP. But once a GP does get a positive diagnosis, we are expected to inform the patient of the result, a positive result, within a 4-week. I guess for me, referring to Tim and Ken, as a barrier, is 4 weeks sometimes a bit difficult trying to actually get a patient back to review a positive diagnosis with a high PSA.
Go on, Ken.
Doctor, if I could answer that, Look, I think working with the other sort of kind of Aboriginal medical services as well, they've got I think most of them have liaison officers and all that, or health promotion. It's kind of like engaging with them to say, hey, look, we've got this patient, it's our collective patient. Could you help in this area? Because the outcome is the the patient gets the best sort of kind of quality service from whichever organization, but working together, they get the best treatment on either side. So it's really working together in collaboration to come up with the best plan of treatment for the patient. And then that takes a little bit of talking, but we've got to do that because it's the patient that we want to sort of make sure that they're getting the best sort of service on both sides. So I think it's
just
just
as a, I guess, follow up, a scenario just comes to mind where, let's say, a patient, let's say by the name of David, he's had a PSA, he's had the second test, it's high as well, and obviously there is a high suspicion of prostate cancer. There is attempt by the health services, the nurses, other health systems to contact the patient, but he's not answering. But what happens if, let's say, David's big brother comes to your clinic? For me, is there ability to somehow say, oh, by the way, David's seen me, obviously trying to protect privacy, but to say, do you mind getting David to come and see me because something urgent's come up? Is that actually out of scope, or is that something that using actually, the family networks to get patients in?
That's actually quite appropriate, because it's like, I also look after the rest of the family. I need to better see this other family member too, but I've been trying to track him down and I can't do it. Can I get your help to do this? So it's just asking for help or did he change his number or something? Can I get a new number? So that's appropriate way to sort of engage that sort of kind of reconnect.
Yeah,
so
I'd be asking,
certainly just asking, yes.
Yeah, and the Aboriginal health workers will often be really useful. They often know what's happening for people and where they might be. And even the receptionists and drivers, I've had our transport drivers track people down in the past as well, just because they're so highly regarded in the community. So I think those links into the community, including where appropriate and protecting confidentiality, relatives. I think that Aussie changed his number. Do you know what his new number is? It would be a really nice approach as well.
No, thank you.
Not a problem.
So yeah, and I think what was the other thing I was thinking on that? Again, so I was thinking using the people in the service for doing that. And I think in a sense, we as GPs, we stand with a feet in two worlds. One is translating from medical speak to everyday speak. And for many Aboriginal and Torres Strait Islander patients, English will be their third or fourth language in the territory, quite often, Ken, I think. And
yep, that's right. Yep.
There's literal translating to be done there, less so where I work, but explaining things like Gleason scores and explaining what those sorts of things mean, and finding out what people understand about the diagnosis once they've been informed, and giving them time to have questions then and also later on. And quite often people will have cultural explanations that we may not be familiar with for particular diagnoses or particular sets of symptoms, and sometimes that can be a helpful thing to ask. Sort of, what are the sorts of explanations that your parents or grandparents might have had for these symptoms or this diagnosis? Who are the sorts of people who you'd like to get involved in care? Other nunkeries who might be involved? And often that sort of approach means that you can really tailor care very well. It's not a rejection of what we're offering, but making sure that they're accompanied in their care by people and systems that they feel comfortable with.
Yeah, that's right, Dr. Tim. Where this is where you're more than just a communicator of this. You're the animator of how this communication happens. So like you might say, well, how do people talk about diabetes? And what's the nuances? This is where if you start using some of the actual Aboriginal language nuances, then others will go, I've got that, and I'm going down this track now. So, but what do I need to understand? So this is where using the actual Aboriginal nuances, pronunciation of some of the illnesses for that particular region gives a more or less of a communal understanding of what it is.
And your patients will often guide you about that. Yeah.
Yeah.
If we move on, the next slide shows some of the resources. On the right, checking for cancer, what to expect, and on the left, cancer, what to expect. And these are patient resources designed to help us explain to people the sorts of treatment and the sorts of care that they can expect and the sorts of pathways they'll go down. And so this is a useful example of what Ken was talking about in terms of visual guides as well. And so now moving on to surveillance, so in the optimal care pathway for Aboriginal and Torres Strait Islander people, they describe 4 components of survivorship, and that's the prevention of recurrent and new cancers, as well as late effects. Surveillance for cancer recurrence or second cancers, so people can get other cancers as well, and screening assessment for medical and psychosocial late effects. Interventions to deal with the consequences of cancer and cancer treatment. So often side effects are common, and so managing those and the symptoms and distress and the practical issues of dealing with cancer, and the coordination of care between all providers to ensure the patient's needs are met. And sometimes we get help with that from the Primary Health Network funding for what used to be called coordinated care and supplementary services, which are contracted out to different organisations now. So your local PHNs will say what's available in your area. And so that's important in terms of care for the individual, guiding them through the treatment pathway and following them up, looking for cancer recurrence after the treatment pathway, but also providing the whole range of preventive health care and care for other illnesses that they may well have. Aside from that, so we're still providing immunizations, we're still providing other screening measures, which have got to be important to their care. And
so
I think
just on in regards to supportive management, and obviously a patient will go through different platforms of treatment for prostate cancer, but in regards to a GP role, I've seen many patients that end up actually not being monitored for cardiovascular risk factors, and the other one that comes to mind is diabetes and osteoporosis, and particularly for prostate cancer we may end up seeing patients with osteoporosis, particularly if they're on hormone therapy, and the fact that many of these patients post-treatment, their risk of cholesterol going up, diabetes and heart risk goes up. So these are important facets of care for the GP in managing patients with prostate cancer.
Yeah, that's a really important point, because it's easy to just focus on the cancer diagnosis and forget about those other things. And that may be a useful, really useful thing we can do with our electronic health records, is that as well as tracking the cancer care, we can add in reminders for ourselves. Have we checked the cardiovascular risk profile? Do they already have cardiovascular disease, and we need to manage that at the same time as the cancer? So those are going to be important in terms of providing holistic medical care. The other important thing.
Ken. Could I just add there? Yeah. Look, this is where we're emphasising the patient care plan, and part of the patient care plan is just not one way. It's more or less like saying, hey, look, you and I are committed on this journey for your own health. So you and I got to work on this together, which means you got to do a little bit of work there, and I've got to do a little bit of work, and we work together. So it's kind of like emphasising, look, we're a team in your journey, and these are the things that you've got to monitor as well. And like you monitor your a healthy sort of diet, all of those things. You do that, I'll check it, and then it's then reward, not rewarding, but acknowledging that, oh, you've done really well here, so whatever you were doing, keep it up. And then that becomes, oh yeah, my doctor gave me all the green light, I could do this and do this, I just got to continue this. So you've got a really good working relationship that is actually focused on that individual taking on responsibility as well.
Yeah, that's a really good point, and encouraging people as well, because the likelihood is they are doing things well and they're making a real effort. And so finding room to encourage that, people really respond to that. The other important thing I've become really aware of as well is how often the person with cancer goes through all of this, and they sort of come to terms with that quite often, but family members often really struggle because they have less control over the whole process. And so we're family doctors after all, and so it's really important that we take note of what it's like for family members, and particularly whether the patient is maintaining connection to the family, what the communication with them is like, and also whether they're connected to other members in the community, whether they're able to meet their community obligations and cultural obligations, because being connected to family and community and connected to culture is a protective feature that will allow people to maintain their strength and maintain their well-being as they go through cancer treatment. Ken, is there anything more you'd like to say on that? Because I think that's really important.
Yeah, look, that's it allows for the patient to easily sort of explain, look, I can't sort of participate in that, or can't do this because I'm under doctor order. So like this term that's used, doctor order, which means that I'm under doctor's instructions to actually, do things right for myself, and then everybody else actually understands that because there's a level of care plan in place. So it helps the patient to sort of kind of warn off any sort of temptation to either, can have a party or something and having a drink, because it gives them an excuse. And no, my doctor said this. It gives them a bit more a power to say no.
Yeah. And there's a negotiation to be had there about what are the things that are less ideal and what are the cultural connections, like there may be ceremony that people need to be involved in, maybe sorry business they need to be involved in, that we won't necessarily know about, but is important to patients. And one of the things that's going to be important is allowing people to live the life they want to live as they go through this. So that's not partying till all hours, probably, though I guess if people want to do that, we can't stop them, but also maintaining these healthy connections that are going to be the things that keep them going through difficult times.
Yeah, that's right. And by like having like my doctor said this, gives them a really good sort of positioning to say no to a lot of other stuff, because otherwise it's difficult to say no in a lot of aspects. But saying that no, it's for my health sort of condition, I can't do that, and people understand that.
And there's been a real theme to what you've been saying all the way through, Ken, that this is about a partnership between the doctor and the patient in working out how they're going to go through this all the way together.
Yep, that's right.
And that won't be news for people working in primary care. That's the way we aim to work anyway. But I think being explicit about that can be really useful, and sometimes even like explicit with the patient, saying, look, this is a really difficult diagnosis and time. We're going to work together all the way through this. And sometimes just that can be really helpful for patients to hear.
Yep, that's right.
So on the next slide, this is the resources from the optimal care pathways. So there's the optimal care pathways. They have a sort of a full guideline, and then they have a quick reference guide which sort of summarizes it for quick reference. And so there's an image of that over on the right of your screen. And also worth remembering that there are relevant tumor-specific optimal care pathways. So those are the pathways for ideal care for each of a specific group of tumors. So prostate cancer is one of those. And then, so the optimal care pathway for Aboriginal and Torres Strait Islander people can be used with any or all of those different pathways, so that ideally we're using them together to make sure that our Aboriginal and Torres Strait Islander people are really engaged in their care and following it through for their cancer all the way at what's a difficult time for people. And so that's the link there, and that'll be sent out to you as well after the webinar.
That's a fantastic guide too. That looks like it fantastic.
It's been developed well by Cancer Australia, I think. So these are the other useful resources. There's the quick reference, there's the links for the full guide and for the quick reference guide, and the information for health professionals. We also have to mention the National Guide to Preventive Health Assessment for Aboriginal and Torres Strait Islander people. Now it's in 3rd edition. We often just refer to that as the National Guide. That's like the Red Book for Aboriginal and Torres Strait Islander people about the preventive health interventions that are recommended for Aboriginal and Torres Strait Islander people, and essentially forms the evidence base for the interventions that are most useful in an Aboriginal health assessment. And so that's that guideline is there, jointly produced by the RACGP and NACCHO, the National Aboriginal Community Controlled Health Organisation. Those are the links to the statistics presented today, so from the AIHW and the Engaging Aboriginal and Torres Strait Islander Communities in Prostate Cancer Healthcare Programs. Is there anything you'd add about the source for those stats, Justin?
Yeah, no, these are, I think, 2 important documents, and for those who enjoy a little bit of a weekend read, particularly the PCFA report, there's lots of work to do in this area in supporting First Nations health people in this space, and just highlights that we've got things to do over the next few years.
And I do think it's important that we, the fact that incidence is the same or lower for many cancers for Aboriginal and Torres Strait Islander people, but the mortality rates are higher and screening rates are often lower for Aboriginal and Torres Strait Islander people. That puts the ball firmly in the health system court, I think, for thinking, okay, what can we do to ensure that the mortality rates are the same, because they should be the same, and what can we do to ensure that we're diagnosing cancer as early as possible to make sure those mortality rates do come down. And that's often, very often, about making sure that our health services and the health systems are actually welcoming and engaging for Aboriginal and Torres Strait Islander people to come to. Would you add anything to that, Ken?
I'm really encouraged in regards to what I'm hearing. It's absolutely fantastic, and yeah, we're on this journey together.
Yeah, absolutely
Great
right.
work.
This is a reiteration of the learning outcomes, so hopefully we've covered all of those, and we've actually got some time for questions coming through. So Daniela, do we?
All right. So no,
questions?
we don't have any questions. So we'll put that down to a great presentation. So thank you, Justin, Ken,
Yeah,
and
thank you.
Tim. And
Thank you, everyone.
and
thank you, Daniela,
everyone
for hosting.
attending. We hope you got a lot out of this webinar. We certainly did. And so thank you for your attendance. And again, thank you, Justin, Ken, and Tim, for an absolutely great presentation.